Greetings to everyone. We are back again with a new video. My name is Jay Shah and currently I work as an intern. First of all, I would like to thank all of you for the wonderful response which you have given to the previous two videos. I'm truly grateful for that. But as an unintended consequence of it, two things have happened. Firstly, it has inspired me to do even better in whatever little way I can to help you all in this final lap of preparation. And secondly, it inspired me to step up a level bit and go out of my comfort zone in the form of discussing the final year university exam questions. Now, many of my close friends from my immediate junior batch uh, did discuss or did request that I discuss these questions as well. But I was not pretty sure about it for two reasons. Firstly, medicine as a subject is a mammoth one. And honestly, preparing this video for discussion has been a Herculean task for me. And it has taken a lot of perseverance and brushing up old concepts as well. And secondly, and more importantly, I was not sure of my own capabilities if I would be able to put forth the concepts or the questions in a way which I understood, because each of us has a different way of learning. So I've taken the leap finally, and I'm hopeful that my endeavor is rewarded. And as a suggestion, more than appraisals, at the end of the video, I would like you all to give honest opinions, your reviews about it, or if there is some constructive feedback or criticisms, or better still, if you find some inaccuracies which might have crept in inadvertently, please bring it to my notice. I'll be really grateful. And at the end, at the beginning of the presentation, generally we invoke our teachers, and I have been very, very fortunate to learn medicine from a professor whom I adore a lot, though I haven't spoken to him, and I consider him to be, if I'm not mistaken, and it would be no overstatement, the godfather of medicine, and it has to be Dr. Rakesh Nair, sir. He has been an inspiration for lakhs of students like me who were not even pretty sure, and in my case, were not pretty sure if they could reach this far. And if you see me on the screen currently discussing this, it is all thanks to his constant motivation, or his constant chilled out attitude, that you just need to relax, sit back, and understand concepts. All other things will fall into place. So paraphrasing him, just relax, put on your headphones or your earphones, and I'm pretty sure that this would be a very helpful discussion, because many of the questions are repeated and in future will also be repeated for your upcoming exams. So without further ado, let's start the discussion. Uh, the first question is, green color sputum is seen in infection with. Now, Pseudomonas, TB, Shigella, E.coli. What should be the option? Now, TB would not have it, because TB is generally a persistent cough line for more than 2 weeks or 14 days, and it is, unless it is infected by other bacteria, it is generally whitish, or it may be a dry cough, or it may be accompanied by hemoptysis. But green color anywhere, your bells should start ringing that it has to be Pseudomonas, because green colored paronychia or infection of the nail bed with Pseudomonas is also common. So again, there is green pus which is formed. Similarly, green colored sputum is also indicative of Pseudomonas. You can also see it with pneumococcus and other bacteria. But since pneumococcus is not in the option, the best available answer is Pseudomonas. The second question is a pretty easy one, and it is from uh, our respiratory physiology, which is tidal volume in adults. Now, I want you to remember certain values in terms of volumes and capacities. So, tidal volume in adults is 500 ml. Your inspiratory reserve volume is 3000 ml. Expiratory reserve volume is 1300 ml. Residual volume is 1200 ml. Tidal volume is during your normal breath, the amount of air inspired or expired. So that is 500 ml. After normal inspiration, how much amount of air you can inspire in further, that is your inspiratory reserve volume. After the end of normal expiration, how much air you can exhale further, that is your expiratory reserve volume, which is 1300. And finally, residual volume is despite your forceful expiration, the amount of air which you cannot exhale out, that is your residual volume, or that which remains in the lung to prevent its collapse, that is residual volume. So tidal volume 500, inspiratory reserve volume 3000, ERV which is 1300, RV which is 1200. Now that we know the volumes, capacities are basically additions of volumes. So your inspiratory capacity would be tidal volume plus inspiratory reserve volume. Your residual capacity would be ERV plus RV. Your vital capacity would be TV plus IRV plus ERV. That is the total amount of air which the lungs can have, which are, after forceful inspiration or expiration. And total lung capacity is the sum of all values. So total lung capacity would be TV plus IRV plus ERV plus RV. So if there's question with respect to numbers or with respect to capacities, I hope that you can solve them. Inspiratory capacities is TV plus IRV. Functional residual capacity is ERV plus RV. Your vital capacity is TV plus IRV plus ERV, and your total lung capacity is the sum of all, right? The next is, which of the following is a COPD? Now, is it bronchiectasis? Is it pneumonia? Is it pleural effusion, or is it bronchial asthma? Now, none of them is a chronic obstructive pulmonary disease, and I'll tell you the reason why. According to the classification which we have, obstructive lung diseases has COPD, and then it has bronchiectasis, bronchial asthma, and others. COPD among itself has chronic bronchitis and emphysema. So if you see at this flowchart, lung diseases can be obstructive, restrictive, or vascular. So in obstructive, you have COPD, which has chronic bronchitis, emphysema, small airway disease, bronchial asthma, bronchiectasis, cystic fibrosis, and bronchiolitis. Whereas in restrictive diseases, you have intraparenchymal, which is in the form of interstitial lung disease, extraparenchymal, which may be neuromuscular, which may be chest wall related. Neuromuscular is myasthenia gravis, chest wall is kyphoscoliosis, ankylosing spondylitis. Vascular is your pulmonary hypertension. So I want you to remember this diagram very well, because obstructive and restrictive you differentiate in the form of FEV1 by FVC, which is forced expiratory volume and at the end of 1 second upon your forced vital capacity. So in obstructive diseases, your FEV1 by FVC is reduced, whereas in restrictive diseases, your FEV1 also reduces, your FVC also reduces. So the ratio remains constant. So this is the primary distinction between the two. So if they ask obstructive diseases, it will be COPD, asthma, cystic fibrosis, bronchiolitis, bronchiectasis. And in COPD further, you have chronic bronchitis, emphysema, and small airway disease. So the question which is asked is, which of the following is a COPD? So none of them is a COPD, but which of them are obstructive disorders? Bronchiectasis and bronchial asthma, both are there. But if given an option, or if you have to choose one, because since it is MUHS, you'll have to choose bronchial asthma. That is a better bet than bronchiectasis. Condition arising due to hypersensitivity is. Now again, it's a very vague question because they haven't asked which type of hypersensitivity reaction. Is it type 1, is it type 2, is it type 3, or type 4? If you had watched my previous video and on pathology MCQ discussion, again this question was asked that bronchial asthma is which type of hypersensitivity reaction. So it is basically a type 1 hypersensitivity reaction, whereas tuberculosis is a type 4 hypersensitivity reaction. So again, both of them are correct, but if given an option, go with bronchial asthma, because hypersensitivity per se, if nothing is mentioned, we'll consider it as type 1. So type 1 is anaphylaxis, allergies, bronchial asthma, and type 4 is your contact dermatitis, multiple sclerosis, type 1 diabetes, and tuberculosis. So just remember these, it would be helpful. The next question is, Light's criteria is applicable in. Now, Light's criteria, again, it goes to a basic concepts of what is a transudative effusion versus what is an exudative effusion. So as you all know, transudative is because of increased pressure, which is hydrostatic pressure, whereas exudative is because of increased vascular permeability, right? So if there's more permeability, there'll be increase in protein, increase in cells, increase in enzymes. So it will appear whitish or it will appear purulent, whereas transudative will have more of serous fluid. So serous means it will have less enzymes, it will have less cells, and it will have lesser proteins. So Light's criteria, as I mentioned in my previous video as well, it's for pleural effusion, and it's very important. It is asked as an SAQ as well and in LAQs as well. and not to forget your MCQs and your Viva exams. So you need to remember 0.5 and 0.6. So your pleural to serum protein ratio in transudate will be less than 0.5. That is, your pleural protein is less than your serum protein. Similarly, your pleural LDH will also be less than your serum LDH. So protein ratio less than 0.5, LDH ratio less than 0.6, and pleural fluid LDH has to be less than 2/3 the upper limit of normal. So less than 2/3 is effectively meaning less than 0.66. So option number, so the row number 2 and 3 both are effectively the same, but it is just adding one additional row. So remember that protein less than 0.5, enzyme less than 0.6, and pleural fluid LDH less than 2/3 the upper limit of normal. So what would be the main causes? The main causes would be when there is increased hydrostatic pressure or a decreased blood colloidal osmotic pressure, also known as oncotic pressure. So in heart failure, what would happen? Hydrostatic pressure would increase. In cirrhosis, there is decreased protein production. Again, your oncotic pressure will decrease. In nephrotic syndrome, what would happen? There is increased protein loss. Again, your osmotic pressure will decrease. In pulmonary embolism, again, what would happen? There will be congestion in the capillaries. There will be increased backflow or increased back pressure. So again, it will result in a transudative effusion. Whereas in exudative, you need to remember various infections. Be it bacterial pneumonia, be it viral pneumonia, be it tuberculous pneumonia, be it malignancy, pancreatitis, esophageal rupture. Pulmonary embolism per se will generally lead to transudative and not exudative. So chylothorax or hemothorax, malignancies, various infectious pathologies, inflammatory pathologies, all of them will lead to exudative effusions and not transudative effusion. So the question asked is, Light's criteria is applicable for pleural effusion. Correct. And Ghon's complex, again, it's a question which has its roots in second year pathology. So you have Ghon's focus and you have Ghon's complex. Ghon's focus is basically tuberculous bacilli which are there in a particular area. Generally, it is subpleural location. When it involves the lymphatics along with its lymph nodes. So TB focus along with TB lymphatics and TB lymph node, that is known as a Ghon's complex. So Ghon's complex is seen in tuberculosis. You need to remember that. Now, there are various foci with respect to TB, and it would be better if you just know the names of them. So you have a Simon's focus, the only foci to be seen in primary TB, and it is basically a nodule at the apex. So that is Simon's focus. All the remaining ones are example of secondary TB. Now, secondary TB can either be due to reinfection by tuberculous bacilli, or it can be because of reactivation of a latent infection. So generally remember the clavicle. Pull the clavicle. So above supraclavicular is Pulls focus. Below that you have Assman's focus. So supraclavicular foci is Pulls. Infraclavicular is Assman's. Rich focus. The brain is rich in knowledge or something like that. Just remember it. So Rich focus is seen in brain parenchyma. Simon's focus is seen in your liver, and Vigard's focus is seen in your pulmonary vein. So if you know the names, it is well and good. Even if you don't, it won't make much difference, but it is just better to know. So Pulls is supraclavicular, Assman's intraclavicular, Simon's is with respect to the liver, Rich is with respect to the brain, and finally Vigard's is with respect to your pulmonary veins. Right. Pulmonary edema may occur in. Now, what is the pathophysiology of pulmonary edema? Pulmonary edema generally means there is increased fluid deposition, abnormal increased fluid deposition in your interstitial space in the lungs. That is an example of that is the definition of pulmonary edema. So in exposure to high altitude, what happens is for all your systemic vessels, in response to hypoxia, there is generally vasodilation. But what happens in lungs? There is vasoconstriction. So it is postulated that the vasoconstriction leads to an increased pulmonary capillary wedge pressure, and there is more transudation of fluid. So that leads to pulmonary edema. In organophosphorus poisoning, as we know, OP poisoning is an example of cholinergic poisoning because it inhibits your acetylcholinesterase enzyme. So there is excessive amount of choline, and choline will cause all kinds of increased secretion. So again, it will lead to pulmonary edema because the secretions will increase. Again, when we see with respect to LVF, there is increased back pressure in the pulmonary veins, increased pressure which is transmitted to the pulmonary capillaries, and that will again lead to pulmonary edema. Right. So my bad, it should have been vasoconstriction, increased secretions for OP poisoning, and acute LVF. There is an increased hydrostatic pressure. It's not decreased, it's increased hydrostatic pressure. Right. The next question is female with left-sided chest pain, fever. Examination of respiratory system shows decreased chest movements, stony dull percussion, absent breath sounds. What's your diagnosis? Now, this is typical findings for a pleural effusion. Decreased chest movements, stony dull percussion. Stony dull percussion you won't find anywhere. You'll only find it in pleural effusion. Absent breath sounds, again, pleural effusion. So what are the characteristics or the features which you'll get in examination? The patient will come with dyspnea. So that is basically the symptom of the patient. Which are the signs which you'll see? So the signs will be in the form of inspection, palpation, percussion, and auscultation. The complaint is dyspnea. On inspection, you'll see that on the affected side, your chest movements will be decreased. Why? Because your lungs are not expanding that much. On palpation, which is tactile vocal fremitus, it will be decreased on that affected side. Why? Because the fluid which is there between your hands, between the pleximeter and the flexor finger, the pleximeter finger and your lungs, there is fluid. So that will dampen the vibrations which are transmitted to your finger. So you'll find a decrease in tactile vocal fremitus. And on percussion, you will find a dull note. And so the pleximeter and flexor was with respect to your percussion. And on auscultation, you'll again find weak breath sounds above the level of dullness, right? So this is a table which you should go through at least once. Just pause the video. It will help you in your both for solving MCQs as well, because many MCQs are asked with respect to, clinical STEM questions. They'll give history or some inspection, palpation findings or percussion findings, and they'll ask you to diagnose. So considering pleural effusion, there's dyspnea. Yes, there's breathlessness. It's a non-productive cough. There's chest pain. The female also complained of chest pain. She also had fever. That means the pleural effusion might have been infected. Tactile fremitus is decreased on palpation. Then there's tracheal deviation away from the affected side because the fluid will push it to the opposite side. Stony dull percussion. On auscultation, decreased vesicular breath sounds and crackles. Friction rub is also typical. So friction rub and stony dullness is typical for pleural effusion. In pneumothorax and COPD, what will happen is you'll have air, excessive amount of air which is accumulated. So that's why you'll have a hyperresonant note there. Whereas in pneumonia, also there's fluid deposition within the lung parenchyma, so you'll have a dull note, right? But your vocal resonance will be increased, whereas here the vocal resonance will be decreased. Right. So the next question is genetic abnormality which is present in COPD. Now, COPD will also include your chronic bronchitis and emphysema. So talking about emphysema, alpha-1 antitrypsin is the leading cause of emphysema in adults. So there are basically 4 types of emphysema. You have centriacinar or centrilobular, you have panacinar or panlobular, you have paraseptal, and then you have indeterminate or irregular. Now, if there's an enzyme deficiency, it will affect all the acini or it will affect all the lobules and not some particular segment. That's why alpha-1 antitrypsin deficiency will lead to panacinar emphysema, whereas smoking only involves your center of the acinus. What is acinus? Basically a respiratory bronchiole along with its alveolar ducts and alveolar sacs. That is known as an acinus. That is the basic unit of a lung. So centriacinar emphysema is smoking. Panacinar emphysema is alpha-1 antitrypsin deficiency because it's an enzyme defect, so it will affect the entire acinus, whereas smoking preferentially involves the central part of the acinus. That's why it's known as centriacinar emphysema. Right. So again, you can just pause the video and go through it. Centrilobular or centriacinar emphysema, center of acinus involved, most common, seen in smokers, predominantly upper lobe, because there are people, a lot more people who smoke rather than those who have enzyme defects. So centrilobular emphysema is more common. Panacinar is seen in young non-smokers, alpha-1 antitrypsin deficiency. Panacinar emphysema is also generally accompanied by liver cirrhosis, right? This is the genetic basis of it, which is not required. And the last form of emphysema is the penultimate form is paraseptal, which is seen in again young males and which has an increased risk for pneumothorax. Now, why pneumothorax? Because it is generally seen just below the pleura. And if it ruptures, that bulla ruptures of the emphysema, it will lead to pneumothorax, right? Cartagena syndrome includes all except. Now, Cartagena syndrome generally has a triad of situs inversus, bronchiectasis, and chronic sinusitis. Infertility is also included in it, but generally the three typical features are situs inversus, bronchiectasis, and chronic sinusitis or recurrent infections. Why is it so? It is because of the cilia, the defective dynein arm which is there. As a result, you have cilia which are non-functional. It cannot clear the secretions. So that's why it's also known as immotile cilia syndrome. Immotile cilia syndrome, also known as Cartagener's syndrome. And why situs inversus? Because during embryogenesis, the rotation of organs, cilia is required as well. But due to absence or deficiency of cilia or non-functioning cilia, there's ineffective rotation of organs. As a result, you will have situs inversus. And bronchiectasis, because the secretions are not cleared. Infertility, why? Because in your vas deferens as well, there is ciliary movement, which is responsible for the transport of sperms from the epididymis right up to your vas deferens and seminal vesicles, right? Popcorn calcification on chest X-ray is seen, and again, this is a question which you just have to remember. It is seen in hamartoma. Now, what is a hamartoma? Do let me know in the comment section below what is the difference between hamartoma and choristoma, right? The next question is a 28-year-old female presented with diarrhea, confusion, high-grade fever, and on a chest X-ray, she had bilateral pneumonitis, which is the most common organism. Again, you need to remember that this is typical for Legionella pneumophila type of pneumonia. Why? Because it has both typical as well as atypical characteristics of a pneumonia. Streptococcus will not cause diarrhea or confusion. Neisseria meningitis may cause confusion, it may not cause diarrhea. Hemophilus influenza, it will neither cause diarrhea, it will neither cause confusion. So the answer is Legionella. Even if you didn't know that such an organism exists, you could have easily eliminated the options and we could have reached the answer. Now, just a snapshot of Legionella pneumophila. The typical presentation, as in any pneumonia, it would be high-grade fever plus bilateral dense lower lobe consolidation. That is true. Along with that, since it's acute inflammation, there will be leukocytosis, cough, and there's rapid progression of the disease. But what will be the atypical presentation? Sometimes you'll have a non-productive cough as well. You'll have diarrhea in which there is more loss of sodium, so that will lead to hyponatremia. There may be hepatic involvement as well. There may be hematuria as well. There may be thrombocytopenia. So all of these are non-typical presentations of a pneumonia, because in pneumonia, hardly you'll see there's thrombocytopenia or hepatic involvement. Hematuria, you may see after a streptococcal pyogenes infection of your sore throat. And as a sequel of that, you can see post-streptococcal glomerulonephritis. But hepatic involvement and thrombocytopenia are generally not seen. Diarrhea is definitely not seen. So in Legionella pneumophila, always remember it behaves as both typical and atypical. So we'll have both features: high-grade fever, bilateral lower lobe infiltrates, productive cough, at times may be non-productive. Atypical features may have diarrhea, liver enzyme involvement, hepatic involvement in the form of raised liver enzymes, hematuria, and thrombocytopenia. Remember that. In a patient of bronchial asthma, silent chest signifies bad prognosis, good prognosis, indeterminate none. So it's bad prognosis. So there are generally three categories into which bronchial asthma is divided, and I want you to know that, because bronchial asthma has been asked multiple times in your final year exams as well, and it is always better to know. So remember this mnemonic of 3392, triple C, or basically chest, 3392 and chest. Now, why 3392 and chest? Acute severe asthma, you'll have your peak expiratory flow rate between 33 to 50%, respiratory rate generally more than 24 or 25 per minute, heart rate more than 110, and the person is unable to complete a full sentence. So all of these are examples of, or all of these are characteristics of an acute severe asthma, which has been given a better name in the form of status asthmaticus, right? Status asthmaticus is acute severe asthma. Now, what is life-threatening asthma and what is near-fatal asthma? These are terms which you need to remember, because in MCQs, they'll generally confuse you between life-threatening asthma and near-fatal asthma. By synonymity, both would sound similar, but these are distinct entities. So remember that by 33, 92, and chest. By 33 and 92, your peak expiratory flow rate will be less than 33. Your SpO2 will be less than 92. Triple C is for silent chest. C is for cyanosis. Uh, so yeah, H is for hypotension. T is for basically exhaustion. S is again, it can be for silent chest. And T is tachycardia, because tachycardia is bound to be there as well. It may or may not be present, but always remember that peak expiratory flow rate less than 33% of what is supposed to be normal, SpO2 less than 92, silent chest, central cyanosis, poor respiratory effort, hypotension, exhaustion, mental confusion. C can also be for confusion. And near fatal asthma is the one in which your PaCO2 is raised. Generally, it has to be less than 50, but if it is raised more than 50, then we are in trouble, which is requiring mechanical ventilation. There has been a question asked at which of the following types of asthma requires mechanical ventilation? Is it life-threatening asthma? Is it near fatal asthma? So the answer is near fatal asthma, because they have directly picked it up and you need to remember it. So the question against this again is, in a patient of bronchial asthma, silent chest signifies bad prognosis, right? Silent chest is a bad prognosis. The next question is, most common cause of lobar pneumonia is? Most common cause of lobar pneumonia overall. Lobar pneumonia is basically a typical type of pneumonia. And interstitial pneumonia or atypical pneumonia is basically when you have patchy exudates or patchy infiltrates. Lobar is you'll have a homogeneous infiltration. So Streptococcus pneumonia is the most common cause of lobar pneumonia. You need to remember that. This is the flowchart which you need to remember. And community acquired pneumonia or on an outpatient basis, most common cause overall is pneumococci. Even now, it has been postulated that in hospital acquired pneumonias as well, in a hospital setting, most common causes pneumococci. Generally, there's a confusion between gram-negative bacilli and pneumococci. If gram-negative bacilli is given, go for gram-negative bacilli, but otherwise, overall, it's pneumococci. So, Streptococcus pneumoniae, followed by H. influenzae, followed by Mycoplasma pneumoniae, and chlamydia in outpatient. And in inpatient, you'll have Legionella pneumonia, right? And ICU pneumonia is basically all of them, all of these organisms which are very resistant to your typical antibiotics. So your methicillin resistant Staphylococcus aureus. The drug of choice is vancomycin or linezolid. Then you have Pseudomonas. Pseudomonas you generally use fourth generation cephalosporins. And finally, you'll also have Legionella, which is atypical pneumonia. Right, so most common cause overall pneumococci, followed by H. influenzae, followed by mycoplasma. So if a question is asked even in your SAQs or LEQs, you can draw this flow chart. Next is ACTH is produced by which type of bronchogenic carcinoma? Now, there's an important concept with respect to lung tumors, which is known as paraneoplastic syndrome. So paraneoplastic syndromes are those changes or basically the effects which are non-related to the tumor, that a direct correlation cannot be found between the anatomical location of the tumor and the effects which it is producing at some different place. So small cell carcinoma is known to secrete ACTH. So you need to again remember it, it's a fact. So it's a type of paraneoplastic syndrome. And the most common paraneoplastic syndrome is basically hypercalcemia. We had a patient who had a small cell carcinoma many years ago, and she had persistent hyponatremia. And by reversely introspecting, we came to know that she was a known case of small cell carcinoma, which had been operated, but maybe some part of it wasn't removed entirely because she persistently had hyponatremia. So hyponatremia, ACTH, both are characteristics of paraneoplastic manifestations of a small cell carcinoma. But overall, most common paraneoplastic syndrome, if someone asks you, that is basically hypercalcemia. The next question is, Wegener's granulomatosis does not affect. So it does not affect the liver. Again, it's a question which you need to remember. There are basically, Wegener's granulomatosis is a type of vasculitis. So vasculitis is broadly divided into three categories: large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. So this is a wonderful figure to just help you remember the names. You don't need to remember the details of it. Large vessel vasculitis is Takayasu and giant cell. Medium vessel vasculitis is polyarteritis nodosa and Kawasaki disease. Just remember MPK, right? PKM or MPK, anything which you can remember. Polyarteritis nodosa and Kawasaki's disease is medium vessel. Small vessel vasculitis was basically your microscopic polyangiitis, and you had two different names. You had Wagner's and you had Churg-Strauss, but both names have now been changed. Wagner's granulomatosis is now known as granulomatosis with polyangiitis because multiple vessels are involved, and Churg-Strauss vasculitis is now known as eosinophilic granulomatosis with polyangiitis. Right, so granulomatous is just Wagner's, and eosinophilic granulomatosis with polyangiitis is Churg-Strauss. Remember that. So Wagner's granulomatosis does not include your vessels of your liver. You need to remember that. And this is immune complex mediated. You just remember IgA vasculitis, which is Henoch-Schönlein purpura. Right. Now, D-dimer is most sensitive for. Now, D-dimer has emerged as the hero in the times of COVID, because in COVID of late, we realized that it is causing a hypercoagulable state, and there is deposition of fibrin. There is fibrin breakdown products as well. So elevated D-dimer is a very good example of the intensity of clotting process which happens. So earlier it was used for in patients with deep venous thrombosis, in whom we could suspect that the thrombus would dislodge and it could go to your pulmonary vasculature. So pulmonary venous embolism was what we used to suspect pulmonary arterial, because it used to go to the right side of heart and from there to the pulmonary trunk and pulmonary artery. So pulmonary embolism is the answer. For acute MI, generally you will use the markers in the form of TROP-I and CK-MB. CK-MB more than TROP-I because CK-MB rises earlier. Then you'll have acute pulmonary edema. Generally, it is because of left ventricular failure. So your brain natriuretic peptide is generally what is measured. BNP, pro-BNP. So acute MI, CK-MB and TROP-I, pro-BNP for acute pulmonary edema, and pulmonary embolism, you'll go for D-dimer, because D-dimer generally measures your fibrin degradation products. Right, and again, a general question, shock lung is better known as. So shock lung is better known as ARDS, which is acute respiratory distress syndrome. Now, there are other names for shock lung which you need to remember. So shock lung is ARDS, acute lung injury, ALI, or it is basically known as ALI-DAD. ALI is acute lung injury, DAD is diffuse alveolar damage. It is also known as blast lung or alveolar injury. So what is the pathophysiology behind it? If there is fluid in your alveolar interstitium, it can be because of the changes in pressure, which we earlier discussed, such as your liver cirrhosis, your nephrotic syndrome, your left heart failure. So left heart failure will definitely cause pulmonary edema because there will be an increased back pressure, which is transmitted to your pulmonary capillaries. Or it can be because of a non-cardiogenic cause. So non-cardiogenic cause, the prime example is basically pulmonary causes or your infections to the pulmonary parenchyma. So non-cardiogenic pulmonary edema is basically known as ARDS. What are the other names for it? It is shock lung, blast lung, ALI-DAD, right? And ARDS per se. Remember that. Next question is again, alpha-1 antitrypsin deficiency is associated with pan-acinar emphysema. Smoking is associated with centri-acinar emphysema. And the emphysema which has the maximum risk of pneumothorax is paraseptal emphysema, right? And if it is none of the above, it is basically irregular or indeterminate emphysema. Most common lobe affected in bronchiectasis, again, there's nothing much to delve into it. You just need to remember it is left lower lobe. If this question comes, just blindly mark left lower lobe, you'll secure your half mark. Clubbing is seen in. Now, always remember, clubbing is not seen in COPD. Rest all conditions which you can think of. Restrictive diseases, yes. Pneumonitis, yes. My bad. Carcinoma, yes. Not asthma, because asthma is again an obstructive disease, not pleuritis. Basically, in carcinomas of your bronchus, carcinomas of your pleura, which is mesothelioma, in interstitial lung disease, again, you can see clubbing. Restrictive diseases, you can see clubbing, not in obstructive diseases. So restrictive diseases, your cancers, there's a mnemonic for clubbing, which I have included at the end. So we'll go through that as well. But with respect to clubbing, a few questions are generally asked in your vivas as well. What is your Shamroth sign? What are the grades of clubbing? And what is grade 4 basically known as? So grade 4 is basically known as your parrot beak deformity or your drumstick deformity, right? INH induced nephropathy. So INH is basically your isoniazid. So for Management of tuberculosis, the drugs which we had were HRZD and S. Now S is removed. Generally, we have HRZD. So HRZD for intensive phase and HRE for continuation phase. So H stands for your isoniazid, R is rifampicin, E is ethambutol. So you need to know the mechanism of action of these drugs. You need to know the side effect of these drugs and what you give to prevent them, or what you need to monitor, or what you need to look out for when you are administering these drugs to the patient. So INH causes, isoniazid has been known to cause peripheral neuropathy, which is not generally responsive to B12. It is generally responsive to B6. So pyridoxine is the answer. INS neuropathy treated with pyridoxine. Rifampicin generally causes hepatitis. So it is necessary to monitor your liver enzymes every monthly, ALT, AST, and alkaline phosphatase. Your ethambutol causes retrobulbar neuritis. So that can cause red-green color blindness. So you need to check for your vision every 3 monthly or 4 monthly. So these are the main drugs. And when streptomycin was used, being an aminoglycoside, it used to cause nephrotoxicity and ototoxicity. So hearing tests used to be done at intermittent intervals. Now, we move to occupational lung disorders. This question is from occupational lung disorders. Mesothelioma is caused due to. So mesothelioma is typical or characteristic for asbestos. Now, with respect to asbestos, there are particular things which I would want you to remember. You'll see a holly leaf sign. You'll see an obscure hard border sign. You'll see asbestotic plaques. So if the question is holly leaf sign is seen in, so the answer is asbestos. Obscure hard border sign is seen in, again it is asbestos. Which are the markers for mesothelioma? It is basically calretinine and pancytokeratin. If it was just squamous cell carcinoma, you would have seen keratin pearls and intermediate keratin filaments, keratin intermediate filament. If it were adenocarcinoma, you would have seen glands. For mesothelioma, the characteristic markers are your calretinine and pancytokeratin, and the signs seen are holy leaf sign, obscure hard border sign, and plaques. Right. In massive pleural effusion, obviously the mediastinal shift will be towards the opposite side of the pleural effusion, because pleural effusion being fluid, it will push the lung to the opposite side, right? So if it is a massive left-sided pleural effusion, it will compress the right side of the lung. So the mediastinal shift would be towards the right, right? And what are these three terms? I want you to be clear about it. The three terms are trypopnea, orthopnea, and platypnea. So just remember this term, orthopnea. That means when the person is standing, his dyspnea is getting relieved. Platypnea, that means when the person is lying down, his dyspnea is getting relieved. So orthopnea is generally seen in left ventricular failure. That means whenever the person is at in the supine position, the fluid will press upon the diaphragm and it will not allow the lungs to expand. Whereas in the same case, when the person stands up, due to gravity, the fluid will come down and your lungs can relatively expand better. So that person will feel better. Similarly is the case with a pleural effusion on one side. If it is on one side, if the person lies on the same side, he'll feel better. So that is trypopnea, which is change in dyspnea with respect to change in position. But if he'll lie down on the opposite side of the pleural effusion, what will happen is, due to gravity and the pressure of the fluid as well, the lungs will be compressed even further and he'll experience more dyspnea. So it is not a comfortable position for him. So generally he'll lie down on the side on which he has pleural effusion because that's comfortable for him, right? And the bonus question is, what is CARP protocol in COVID-19? It might be asked in your vivas, but do let me know in the comment section below what is CARP, which was used in COVID-19 until recently. It has to do with dyspnea as well. What is the next question? The next question is, common opportunistic infection in immunocompromised host is. And by immunocompromised, generally we'll go for HIV. Like the prototype example is HIV. So HIV infection, the common opportunistic infection or the prototypical infection is generally it's Pneumocystis or Pneumocystis carinii infection. So you need to remember that. P0SI or P. carinii infection. It is generally accompanied by bilateral hilar infiltrates. Right. Status asthmaticus, as discussed previously, it is severe episode of it is basically a severe acute episode of asthma. And what are the drugs of choice? This is again asked. That the drug of choice in status asthmaticus, you need a drug which will open your alveoli immediately and it will not allow it to collapse. So beta agonists are the best, such as salbutamol or salmeterol, followed by corticosteroids because the inflammation will be reduced, and finally your theophylline, which is a xanthan. So immediately you will use beta agonist followed by then corticosteroids or a fixed combination of the two. Generally, you use budesonide and your salbutamol or salmeterol, and then later you have theophylline. So status asthmaticus is an severe acute episode of asthma. Sudden onset cough followed by increase in dyspnea. So that is characteristic for pneumothorax. Now I want you to pause the video, go to the previous slide, which I showed you the findings in various types of diseases, such as pneumonia, pleural effusion, pneumothorax, right? And to go there, because this is again very characteristic, sudden onset cough followed by increasing dyspnea. Because in pneumothorax, just before pneumothorax, a precipitating factor will cause cough, but once that once there is air which is there in your pleural cavity, the dyspnea will progressively increase. So progressive increase of dyspnea is characteristic of pneumothorax. You need to remember that. Lobar pneumonia will not have sudden onset cough followed by increasing dyspnea. The cough would be gradual. It will not be sudden onset. Neither in pleural effusion, you would have sudden onset cough, and it would be a non-productive cough, right? Tuberculous effusion is characterized by all of the following. Again, remember the Leitz criteria in front of you: protein less than 0.5, enzymes less than 0.6, and your pleural LDH basically less than 2/3 of what your upper limit of normal would be. So tuberculosis is an example of an exudative effusion. So it will have more proteins, yes. It will have serous to serosanguinous, that's true as well. It will not be exclusively hemorrhagic. It will have some amount of serosanguinous or serosanguinous plus purulent. Pleural fluid LDH, more than 60% of serum LDH, yes. So as I mentioned earlier, Leitz criteria is very important. So just go through it once again. Leitz criteria and your classification of asthma. The next is smoking is a risk factor for all except liver malignancy. Maybe as of now or till now, the link has not been established, but in my not so humble opinion, basically there's no malignancy which does not have smoking associated with it. So if there's this question asked, smoking is a risk factor for all except, since the answer is given as liver malignancy, do remember that. Next question is, which of the following is not used in bronchial asthma? So salbutamol, formoterol, and salmeterol, all of them are beta agonists. So they are used in asthma, whereas tolbutamide is, it's an OHA, it's an oral hypoglycemic drug. So it is basically a sulfonylurea. So tolbutamide was an old generation sulfonylurea. Now we have glibenclamide, glipizide, gliclazide, glimepiride. And so this classification of oral antidiabetic drugs or oral hypoglycemic drugs is oral hypoglycemic drugs is very important, because diabetes as an LAQ or an SAQ or from the MCQ point of view is also very important, and for clinical practice it is important as well. So for increasing your insulin secretion, you generally have your potassium channel blockers or DPP4 inhibitors. Potassium channel blockers, again you'll have sulfonylureas or meglitinide analogs. Meglitinide is simple to remember, it is repaglinide and neteglinide. DPP4 inhibitors, remember by like Sita, Lina, Sexa. So sitagliptin, saxagliptin, linagliptin, vildagliptin. All of these will increase your insulin secretion, provided that specific amount of beta cell mass is there, at least 70% is there. Now, in the second part, when you want to overcome insulin resistance, that means your insulin production is more than adequate, but your sensitivity is not there. And there is resistance. So to increase your sensitivity, you have biguanide. The most widely used is metformin, which is by the brand name Metexel 500. It's a bread and butter. And again, you have thiazolidinones, which is pioglitazone and rosiglitazone. Miscellaneous drugs, glucosidase inhibitors, amylin analogs, dopamine agonists, and sodium glucose co-transfer inhibitors, SGLT2 inhibitors. So just remember these drugs if you can. So enhancing secretion, overcoming resistance, and miscellaneous category of drugs. And so we'll end with the first session of it, partly because there were close to 90 MCQs which were there, and I did not want to record it in one go. So this is the first session, and this next session is upcoming. I would like to end with this quote that maybe wherever you are, whatever happened was good with respect to this past 1 year. What's happening, just continue doing that with your preparation. Don't be scared. Anxiety is pretty normal. Stress is pretty normal. You'll make through it. Whatever will happen will also be good. And do not have any baggage from the past. Not worry about the future. And let's live in the present, be it with respect to our friendships, relationships, or anything. Let's not worry about the future. What is meant to be will be, and let's not have regards from the past. And as a parting shot, since we are living in unprecedented times under the shadow of war, uh, in my personal opinion, my heart goes out to the people of Ukraine, and with much love from India. uh, yeah, Ukraine is always in our players, right? Thank you.